So, welcome back, Dr. Toker. We are here. We're actually both in Dallas, but I'm on one side, you're on the other, and just separated by a highway. And of course, when I'm sitting in the operating with you on Monday morning, you're looking at your patient that you are taking care of from a rectal prolapse standpoint, and I'm in the back taking copious notes. I'm going, you know what? We need to talk about this topic because many times the introduction in the space that I live in is from having a dermal allograft like Venu for the posterior compartment. And it's very effective, but it's only effective if you address the entire problem. And that's really where we started. So, talk a little bit about your patient, how they presented, and then what you went about correcting it. And then, of course, you had gynecologist that's going to come follow and address the vaginal component.
Yes. Yeah. And normally I would do that with the gynecologist at the same time, but he was stuck in another city. We had a little bit of travel, a little bit of a weather. But basically, I do a lot of my procedures of rectal prolapse and outlet obstruction constipation at the same time as either GYN or a urologist or whatever, because these diseases travel together as a little pack. Basically, and I think a lot of people underestimate the importance of quote unquote constipation in a woman who is complaining of rectocele, cystocele, vaginal prolapse, or whatever the case may be. Because constipation is not necessarily just, oh, well, you're an older woman. It is highly
eat more fiber.
Right? It gets so ignored by, and it's an easy test to identify. We can talk about that also. But basically, if a woman has a 15 to 20 year history of constipation and you are looking at a rectocele, cystocele, vaginal prolapse, some sort of pelvic floor issue, incontinence of any way, shape, or form, you have got to evaluate the rectum for the same prolapse process because it all happens as a team. And in fact, it's kind of the philosophy of most colorectal surgeons that the rectal component probably starts first. And all those years of straining with blockage just slings everything further, collapses everything further. And so you have to address that. And it is shocking to me how many people with a rectocele or a cystocele, they get sent to, let's say, urogynecologist who fixes it without addressing the issue at all. And I've had some
with the constipation, right? Because that's really that cheap. Right. So they're saying, well, you have constipation, you have a bulge, right? You've got a hernia.
That's old fashioned thinking, not to call all the surgeons out there old fashioned, but we used to think that it was the bulge that caused the constipation. But in the overwhelming majority of those patients, it is the constipation that led to the bulge. So you can patch that bulge all day long. In fact, you'll make the constipation worse because now you're cramming the rectum into a smaller space and it really starts to block on itself. So, you have to address the components. Very simple. There's an x-ray. I personally like something called an x-ray defecography. That's a fluoroscopic exam. There are some people who send the patients for MRI defecography. I don't like that test because the patient is lying on their back and being told to try to poop. Well, I don't know about you, but you're never standing up or laying flat when you're trying to poop. It's a very abnormal thing. Plus, psychologically, you're like, no, because then I will poop on myself. And these women have very weak muscles typically. So they don't want to do that. And you can miss a lot of components of rectal prolapse with that MRI approach. That is my experience, that the fluoroscopic one is better unless they have an open air MRI where you're sitting in a chair. But I don't ever have that.
With the squatty potty?
With the squatty potty. and then, okay, MRI. But the x-ray fluoroscopic stuff, it's easy to set up. If your hospital has a fluoroscope, you build the chair. Like we built this chair out of PVC pipe and radiolucent materials. It's just a bedside commode, basically,
Right.
that has see-through compartments to it, so you can film the patient's pelvis from a lateral standpoint. And the radiologists know how to read that. That's part of their residency training, So that is a better test. And even that's not perfect because the consistency of what they're squirting in there is not exactly poo consistency. It's like oatmeal. So you don't have to strain very hard to empty it. And in some patients, they say, well, that was so loose, it just kind of fell out of my body. I didn't have to strain at all. And so therefore, this test doesn't help. So there are some patients where I kind of blindly have to take them to the operating room and just kind of, okay, if your rectum is prolapsing, I'll fix it. And if it's just mucosal prolapse hemorrhoids, I'll fix that. And there may be nothing for me to fix, physical therapy. So sometimes I can get a patient to sign on to that routine. But anyway, so the lady that we saw on Monday is one of these people, 20-year history of outlet obstruction, constipation. She has a quote unquote vaginal bulge. I saw her in the office and her vaginal bulge is kind of odd because there's a cyst in the rectovaginal septum, which I don't do that. I know the word rectum is in rectocele, but I don't fix rectoceles. I certainly don't fix this cyst.
You're not entering the vagina.
No. I'm a one-hole wonder. I only go one place, right? So anyway, so she has all the signs and symptoms of outlet obstruction constipation. She's got some perineal descent. She strains a lot. Her colonoscopy was normal. She's a little anxious. There's a personality type that goes with outlet obstruction constipation. They've got that push me, pull you personality type. You can understand why that would happen. If you couldn't poop, you'd be the same way, right? So it's like a 20-year history of I don't have 4 hours to try to poop and I just can't handle, and it drives them insane. And they have that demeanor. So you've got a lady who's like gets emotionally verklempt when she talks about how bad her constipation is. And she's got a destroyed pelvis and an abnormal sort of vaginal configuration. So we do a colonoscopy, prove everything's fine. And then we do what's called a defecography. And she has an anterior rectal wall prolapse, which means, on the lateral view, they could see that anterior rectal wall snap shut. In fact, it almost gets to the anal canal and it traps contrast between it and the vagina, right? So that's the x-ray finding. You're not fixing that with the vaginal surgery. In fact, you'll only make that worse. So fine. I need to fix that, but she has a vaginal problem as well. Her gynecologist says, well, it's very weird, but it's a cyst. It's not really a rectocele. But he was going to go in there and remove this cyst. And so that was the plan. But he got stuck at an airport in Florida or South Carolina, something like that. So now it's just me operating. And basically I do in these patients, if they still have a uterus, if they don't have any abdominal complaints, then the fewest amount of complications and the quickest recovery is going to be a transanal approach, where basically I use special retractors to kind of see that anterior rectal wall. I disconnect it from the low rectum. And in her case, it was much worse than the x-ray described. So we did a circumferential, a full thickness incision, mobilized a little sleeve of the rectum. So I pulled out a little 4 centimeter length low rectal sleeve, truncate that, and then I reinforced that rectovaginal space with this non-autologous graft. And then I suture that in place. Boom. She does well. She goes home. So now all we have to do is sit and wait and let that heal. And then he'll fix his rectocele and cyst thing. If we do it at the same time, oftentimes they are using that non-autologous graft from a different angle. So now there's 2 pieces of this graft, sandwiching.
One above, one below. on the posterior
Yeah.
compartment
Yeah.
in between the rectovaginal space.
Correct. So that's
And so in essence, you are realigning her fully.
yeah, you're not. There's a couple. Yeah, you're doing a couple things. You're taking the volume out of the rectum. So these people tend to have really, over many years, have kind of destroyed the stretchiness of the rectum. So you're getting rid of that stretch to a degree. You're trying to decrease the volume. You are reinforcing at least some of the pelvic floor musculature. You can't shorten the colon or lengthen the rectum. Like when we do an abdominal approach, we lift it up and out of that space. And so that changes all the angles of defecation, which make a difference. And so we can't really change those very well perineally. But I would say 90% of patients are happy with that approach, and the recurrence rate is, somewhere around 10 to 15%, which is what it is if you did an abdominal approach. So all things considered, for it to have less of a hernia risk, I've never had an anastomotic leak with a resection rectopexy, and I've done thousands of that procedure. So that is even the abdominal approach is very safe. The perineal approach, because I do it in combination with the gynecologist so frequently, is actually a higher risk of complication, because now we're working on both sides of the rectovaginal septum. And we've had 2 patients develop a fistula, which was easily repaired and not a long-term complication. You hate to see it when it happens, though. And I've never
For the layperson, fistula, small hole.
is where inadvertently the rectum is now leaking through the vaginal incision. So the rectal incision and the vaginal incision are actually in 2 different planes at 2 different heights, so to speak. But if you get a blood clot in that space, if you get diarrhea post-op, and these patients are always on laxatives, it's hard to emotionally separate them from their laxatives because they've been laxative dependent. And so many of them will experience diarrhea the first 1 or 2 weeks, but diarrhea easily gets in between stitches and can get a space infected, especially if there's a little blood clot in there, because that's a medium that can easily get infected. So anyway, little diarrhea, 2 surgeons operating at the same time, a little blood clot in between those 2 spaces, boom. You can get a little connection. When that happens, nobody panic. It can be repaired. I've only seen that happen twice. So, and it was easily repaired with 1 procedure, but that is a risk of the perineal approach in combination with another surgeon, that potentially you'd have 2 incisions touching each other and they would communicate. So that is the risk. Buyer beware. But I have done that surgery thousands of times. I mean, in the last 20 years.
You have.
I mean, how many pieces of that graft have you sold my hospital, Rob? So it's like, I mean, it's a lot. So,
Wow.
anyway, and the risk of complications is not quite 0, but it is close. And abdominally, I had never had a complication. I take that back. I had 1 person that had von Willebrand's, which is sort of like it's a bleeding disorder. And her clotting factors that we gave her weren't quite enough, and she developed a little blood clot back there. Okay. But she has a known history of bleeding disorder. A normal person is going to handle this surgery quite well, almost no matter how old they are. So anyway, that's
So for the ladies that are watching this,
yeah.
I think that the take home messages, they might go to their pelvic floor specialist, albeit a urologist, urogynecologist, someone who, gynecologist that practices this type of repair, and you have constipation.
Find a colorectal surgeon.
There it is. Find a colorectal surgeon.
It's very shocking how many of the people who've come to my office who've had a rectocele repair, who told their doctor they had constipation, and that doctor told the patient, I will fix that. And all they did was rectocele repair. They didn't fix anything. And a lot of those patients come to me and like, I am worse now than I had that surgery. Or that surgery lasted 3 months. And then because I'm so constipated, and then I got yelled at for being constipated. But I told them I'm constipated. So anyway, if you
So that is the purpose of this conversation.
yes,
So that they go ding ding ding. If you're not connecting me with the colorectal,
yeah. And I know some gynecologists who have stopped doing the procedure because their failure rate was like 40%. I said, that doesn't mean you're a bad doctor. It meant you didn't involve me in the case. Because that,
well, you're not addressing the problem, which happens to be below the pelvic floor. And I think you exactly pointed it out, is that her rectocele is a byproduct
oh,
of
the prolapse. Correct. You have an internal rectal prolapse, which is called this blockage. And that blockage has led to pressure, which has popped out this rectocele. So all rectal prolapse patients have a rectocele, every single one of them. And so probably 40% of people with rectoceles have this prolapse. So the two go hand in hand. And if your doctor has not ordered that x-ray or thinks they don't need a colorectal surgeon, find another doctor who understands this space.
a combo. It's a combo.
It's a combo. But and I used to be in practice. We recruited a guy. We recruited a guy who was a urogynecologist, and he knew. I'd like, look, we share so many patients. Like, someone comes in with a rectocele before you operate on them, order this X-ray. Let me know if I'm involved, and we'll work together because your outcomes will be improved as a result of doing that. He refused to do it. He kind of got drummed out of town because in my part of the city, they are so accustomed to good outcomes because it always involves a team. It doesn't have to be me, but the doctors who do pelvic floor stuff, the front half, so the vagina and the bladder, they know to involve someone like me, either me or there's one or two other surgeons in town that do this kind of work, colorectal surgeons. So they know. So in my neck of the woods, it's like frowned upon if you don't get everyone involved. Right. Because there's no one doctor there's no such thing as one doctor that does it all. They don't.
Not in that space.
No. And like I said, I'm sitting there fixing the prolapse, but no, I do not fix the bulge. And I'm happy to fix your prolapse because I had some patients get frustrated. Yeah. The rectal prolapse, I'm happy.
Prolapse.
The rectal prolapse, I'm happy to fix. But when I'm done doing that, you are very likely still to have this rectocele bulge.
Because you stretched that out for the last 20 years and you got few kids, vaginal delivery.
Exactly.
It's not just going to magically go back.
There are some, but before I had a team of pelvic floor urologists that I was in partnership with, I would do the case, and then if the patient wasn't happy, then I would ship them, or they would do a case and the patient wasn't happy and they'd ship them to me. There are some patients where the rectocele is only bothersome because they had constipation and had to push against it. Okay, that person may never need a rectocele surgically repaired. It may never bother them. But I will say the group that I refer to are pretty good at figuring out, look, this rectocele is so small, it only swells when they strain. If you make the straining stop, the rectocele will not bother them. And then there's the rectocele, and of course you've seen them because you fixed them, where it looks like a baby's head is constantly crowning. Right. That ain't going away with what I do. I could tell you that. It's like, that's kind of that. So anyway, it kind of depends on severities, but I would say yes, always you need a board certified colorectal surgeon, and not to be sexist, but most people doing these surgeries happen to be female. There are some male, very good colorectal surgeons who do this line of work very well. But
you don't know any.
I know one guy. I know one guy who's good, who's retired, and then
he doesn't count.
What's that?
He doesn't count. Then he's retired.
He does not count. And then there is another guy in town who's, he'll give it the college try, but he hates doing it. And he usually tells these women they don't have a problem and move on. So, but the females in town will do the entire workup because we know, right?
Yeah.
Most of our
So why does this happen more in men, or I say in women than in men in this scenario? I mean,
well,
you've got
the male,
anatomy.
yeah, it's anatomy. The male pelvic outlet is this big. If you've seen a male pelvic bone, not to disappoint some of the people in the audience who might realize there's not a different, like there's a different. The male pelvis is an outlet about this big. The female pelvis is an outlet this big, right? Because a baby's head has to go through this outlet. And so with
And,
a,
and oh, by the way, it gets even bigger during childbirth.
of course, and it's right in all stretches.
Right?
Okay, so now
Stretching.
you've got a bony opening this big, and the muscle layer is this thick. And then there's supposed to be a couple of tendons holding things that have all stretched because of the baby. So there's really nothing filling this space. I tell patients, it's like, imagine a world where you had some frozen water. So you have water, you put it in a freezer, you dangle a string in that water until it freezes, and it looks like it's standing straight up. That's awesome. That's the young female pelvis, rectum, straight up and down. That is amazing. Now, as you age and the water melts, what happens? That string is going to get soft and it's going to start sinking to the bottom of the little cup there because there's no more structural support. The rectum does the same thing. It starts curling into the rectum. So in the male pelvis, there's no room for that. You've got an outlet this big and a prostate that big, like it's rectum and rectum only. There's no
It's
room.
not a straight path. It's a straight path.
Path. But in women, there's a lot of shit going on, right? So big pelvis, thin, the rectum starts to get a crazy angle. If they've had a hysterectomy now, it's at two crazy angles, a scarred angle up high, and then the low slung angle. So I'll look at these rectums that are doing this crazy zit formation. How this poop figure it out. Yeah, well, and the problem is you'll get the signal, the muscles that signal, hey, I got to use the restroom, or just that really thin muscle. It's like a thin china bowl. It's thin. And if it feels a little heaviness, it thinks, I just got to poop. The problem is if you've got a mile of colon gnarled up in the pelvis, you get the sensation you have to poop long before the poop gets there. But the brain thinks I got to poop, so you'll keep straining. But there's
It's not there yet. It's not there yet.
But every time you strain, you stretch.
Right.
The 20 years,
So here's a good analogy.
20 years of that stretch are the problem.
When you think about this, all the women, you know how you go to the airport and you have TSA pre, and that line is straight.
Yes, that's the male.
Okay, that's what the guys get to go. They get to go TSA, and then you have the women, and it's always, they never take the gates down, right? And they go, oh, TSA pre is closed.
Yes.
Literally, I had this when I went through the airport here recently.
Yes.
I literally go, I'm dizzy. I go, because I literally went around. I mean, like they opened up any of the gates, and they were ripped.
It's like being the only person they're going to make.
It literally took me 3 minutes just to get to them.
Right? But you got your steps in. Right? So
what's that?
You got your
I got my steps in, but I was literally, but that's a good analogy though for women compared to men. Yeah. TSA free, straight line, and then here women, all the way.
Oh my god! Oh my god! But anyway, so yes, and then when you strain, you stretch, and as you stretch muscle, you stretch tendon, and then you also stretch the nerves. And as years go on, you stretch the nerves. Now you're incontinent, and now you have the dreaded I'm constipated and incontinent, which means I have to take a laxative because I'm constipated. Well, that gives me diarrhea, and now I'm incontinent. And so these women are like miserable, and then they're homebound. Right. And so the goal in life, and this was my mission for 20 years, because when I started, I had just had a baby. I'm thinking, oh my God, this is going to be me when who's going to fix me when I'm 55 and pooping on myself? But anyway, and now I'm 56, not pooping on myself. Thank you. But anyway, so you want to catch this early. So I've got some patients that are in their 19, 20, 25 that are already straining to have a bowel movement. They've not even had kids yet, but their anatomy is already showing this prolapse. That's the person that when they're 55, the rectum's turning inside out, they're incontinent, and now you can't put Humpty Dumpty back together again. So you do want to intervene early.
So what would you do with a patient like that? That's in their 20s and they've already
I
been
do the workup.
straining.
I do the workup for outlet obstruction constipation, and if they have an internal prolapse, I fix it.
Okay. Because it's not going to present vaginally.
No, they don't have a rectocele. No, they're not. They're not coming in with a rectocele. It takes decades for that rectocele to show up. Flipped. This is someone who they may come in because they have quote unquote hemorrhoids or they've got pain or whatever constipation that no one can fix or whatever. And then it's just a matter of me hearing the story and doing the very weird x-ray. But I mean, I have patient and there's a manometry I do looking for a condition called Hirschsprung's disease, which can show up in that age category. But and but I mean, I have a patient that when I first started my practice was 20, 19, 20. She had this condition. We fixed it. She went on to have a couple of kids and then she developed sort of a recurrent problem. It's fine. I did a resection rectopexy. Like she's now 45. I've been doing her colonoscopies because she's an old lady. I mean, she's been my patient since the beginning of time. Actually, I think she has short segment Hirschsprung's. That's what I did first. I did the surgery for Hirschsprung's first, and then like an internal prolapse, and then she had a decade after babies had a recurrence. We did an abdominal surgery at that point, and then now I'm doing her screening colonoscopy because she's old enough to have it. So, like, I don't mind starting young. And
But if you wouldn't have treated it early,
oh no,
and intervened, what would her life have been like?
it would be now she's coming to me at 45, incontinent. She's destroyed all the muscles. The prolapse may or may not have finally succeeded in turning inside out. Of course, her bladder would be inside out, as would be her vagina and the rectocele and the uterine prolapse and all that kind of stuff. She'd be a full rectal prolapse, vaginal prolapse, bladder prolapse type patient, and with recurrence after recurrence after recurrence at a young age because it was missed, and 2 decades went by with this misery. Like that's the patient with incontinence and the whole kit and caboodle. So that is what happens. These patients never have a 3-month history of this problem, and that's what I'm finding. It's decades.
So how do you limit yourself? How do you not expose yourself to this type of? Is it just genetics or is it lifestyle? Is it
genetics? Is some of it's genetics. Like if every woman in your family has struggled with constipation, okay, that might be a collagen problem. If you're super duper flexible, there's a problem. If you're avoiding using the restroom because it takes you 45 minutes to strain hard enough to poop, there's your sign. If you're on multiple laxatives and it still doesn't seem to help, there's your sign. So those would be a reason, like you're not well, I know not to eat a block of cheese, but I was at, whatever fondue place and I got constipated or whatever. We're not talking about that. We're talking about the person
full time, 24/7.
24/7. It's a constant. And they will limit themselves to one bowel movement a week if they're lucky because they have to take a day off. So they choose a weekend where they just plow down the laxatives and that's the day they poop. And I do try to encourage those people, don't wait an entire week. You're destroying things. Do something every night, every other night in a milder format so it's not that way. Utilize an enema if you have to. We're doing the workup. I want to fix it. So just kind of engage in these activities so we're not making it worse while I'm waiting to do all my x-rays and get you to the right. They're going to have a vaginal bladder thing. I got to get them over to my friend who does the front half of the body. So
Right.
Anyway, so that's what I would say. If it's like, yeah, that's me, then you got yourself a problem. You should probably find a colorectal surgeon and have them do that work.
And if you cannot find one, get on an airplane and
You could come to Dallas.
come to Dallas.
Oddly, I do have patients from all over the country who have come to see me for diverticulitis for this particular problem. It is strange to me, but yes, they do, and it's fine.
Well, I think it's because you listen
Yeah.
and
Yes, in word of mouth. So it's like the people know if they come to see me, they're getting these x-rays. I don't want to hear it's an emergency and I need it fixed now. No, this has been going on for 20 or 30 years. I'm the only person in Dallas who does this kind of work really to any kind of volume. No, you're not having an emergent, let's fix it now. And I've had a couple of patients because they were on a hard up against insurance where I've gotten them into the operating room and it's never really been satisfactory because you can't perfectly fix this problem. So when you run someone to the operating room immediately, I think they get the impression they're going to be totally normal at the end of this process, and they're not. There's no such thing. We're not replacing your rectum. I'm just putting it in a normal spot. You might still need laxatives. You might still struggle with constipation from time to time. 15% chances is coming back. And we haven't had a chance to do physical therapy. Like, I don't like rushing it because I think people get a misunderstanding of how complex this problem is. And it's extraordinarily complex. So
it's not a knee replacement.
no, it doesn't come in a box. The graft comes in a box. Thank you, Rob, for that. But that is just biologic tissue that your body's supposed to incorporate. It's like you are required to hire you. Like you have to heal.
So how does Xive 7 play into this space?
Well, I like this. So one of the things that I have found in my patients with this problem, really all of my patients, to hell with it, even if they don't have a surgical problem, they totally and completely do not see how the upper part of the GI tract is related to the lower part of the GI tract. They don't understand that it is a huge problem to wait a week to use the restroom just because it's more convenient or whatever, because things aren't working properly. You do want to have all systems firing along that tube, whether it's the esophagus, the stomach, the small bowel, the colon. You want all of them kind of in optimal behavior. And so Xive 7 is one of those supplements that actually does support from teeth all the way to anus as far as the digestive system, between the digestive enzymes and the bitter herbs and the probiotics and the prebiotics and the anti-inflammatories, kind of getting the whole system in check. So I don't want to release patients after the surgery to the same behaviors that led them to my place. Now, a lot of people don't get it's what you're eating. It's what you're not eating. It's what you're eating. You're not drinking enough water and you're not maintaining yourself well enough. And so that is a great place to start before surgery and to continue after surgery to kind of maintain things so you don't. I'm trying to minimize your risk of recurrence. And so those patients will get that and they will get some physical therapy. I have a little chair in my office that people sit on for physical therapy.
Right.
And all those things are designed to
And even men can benefit from that, Jared.
Oh my God, yes. Oh heavens, yes. Anybody with a pelvis. So unless your pelvis has been removed, you can benefit from that. It helps bladder function, rectal function, vaginal function, prostatic function, erectile function. So anything
In that
area, it's going to help. Male or female, doesn't matter.
Male or female.
Yeah, it doesn't matter.
Yeah.
It's my magic chair.
It is.
Yes. Yes, my magic chair. You got to ride the lightning of my magic chair, for sure.
All right. That's a great place to push pause.
Yeah. Yes. Indeed.